Today, we are strapping in for a truly mind-bending journey. We're going into the world of central nervous system stimulants, CNS stimulants, and the very ambitious frontier of cognition enhancers. And just so you know where we're coming from, this deep dive is powered by some heavy-duty textbook sources. We're talking pharmacology guides that categorize and really explain the precise action of these powerful chemicals. We're going to be tracing their story from, historic poisons that act almost instantly, all the way to modern wakefulness agents, and even the really complex treatments we use for conditions like Alzheimer's disease. So if you, our listener, are looking for a clear roadmap to neuropharmacology, maybe you're trying to catch up on a medical field, or you're just intensely curious about what these things actually do to human brain, we are here to provide that shortcut. We're looking past the myths, past the street names, and focusing squarely on the mechanisms.
That's right. And to start, clarity is everything. It's so important because we're tackling two very distinct yet related categories of drugs, and you really can't confuse their goals. First up, we have the CNS stimulants.
Okay.
These are drugs designed pretty much for one thing, to stimulate the central nervous system. This can be a global stimulation causing widespread excitement and arousal, or it can be more targeted, improving specific brain functions like attention.
So it's about boosting what's already there.
Exactly.
Yeah.
It's all about boosting existing capability. Then second, we move to the cognition enhancers. These are also called serotoproactive drugs. And this is a much more, let's say, heterogeneous or messy group of compounds. They were specifically developed for conditions defined by neurological decline.
We're talking dementia here, mainly.
Primarily dementia and other severe cerebral disorders, yes. The goal of this category is completely different. It's about repairing or, maybe more realistically, slowing down the deterioration.
So one is pushing the gas, the other is trying to patch the engine.
A perfect analogy. One group is driving the system harder, while the other is, frankly, fighting a losing battle against decay.
Okay, so let's unpack this. Our mission here is to gain this knowledge quickly but thoroughly. We want to give you those key insights that really stick. We need to understand not just what these drugs are, but how they work, molecule by molecule on the nervous system, and why a specific mechanism leads to success or failure. Why are some still used today, and why are others just, historical footnotes or straight-up poisons? So let's start where the chemistry is most aggressive. We're going to begin with the most intense, I would say violent, chemicals on our list, the convulsants. These are the chemicals that stimulate the CNS worldwide, and their effect is dramatic, it's immediate, and it's often lethal. They don't try to boost anything specific, they just ramp up the whole system until it hits a critical failure point.
And what's fascinating here, and this is a really key insight for understanding all of neuropharmacology, is how they do it. The most dangerous global CNS stimulants. They often get their effect not by pushing the gas pedal, as you said, but by attacking the brakes of the entire nervous system.
Oh, okay.
And the classic, honestly a horrifying example here, is strychnine.
The infamous poison, right?
Exactly. It's a naturally occurring alkaloid from the seeds of the Strychnos nux vomica tree. For centuries, it's been notorious. And even though it causes these global, widespread convulsions, its mechanism is surprisingly focused. It attacks the brakes, but primarily in the spinal cord.
The spinal cord specifically, not the brain.
Primarily the spinal cord. It produces these reflex, tonic-clonic symmetrical convulsions by blocking the postsynaptic action of an inhibitory transmitter. And that transmitter is glycine.
So we had to pause here. Glycine. That's basically the primary safety mechanism for our motor system, right? In the spinal cord. It stops us from overcontracting muscles.
It is. It's the stop signal.
And strychnine just throws a wrench in that one. Crucial safety gear.
Precisely. Glycine inhibition is one of the most clearly demonstrated sites for regulating muscle contraction. There's something called the Renshaw cell motor neuron function, and glycine is essential for it. So by antagonizing this essential inhibitory function, the whole system just loses all restraint.
Meaning any input gets a maximum output?
Any input, the slightest sensory stimulus, a light touch, a sudden noise, a change in temperature, it causes a maximum agonizing muscle contraction.
Yeah.
Generalized throughout the entire body.
Wow.
The muscles seize up symmetrically, and they do it so powerfully that victims have been known to break their own bones. It's an absolute medical crisis.
Which explains the treatment then. I saw it similar to status epilepticus.
It is. The historical treatment for strychnine poisoning mirrored that exactly. You have to use massive doses of sedatives like benzodiazepine to urgently restore that inhibition, that braking power, before the chemical damage becomes permanent or the patient succumbs to asphyxiation.
That really puts the mechanism in context. It's not about adding power. It's about removing the counterpower. So then we have its cousin in this world of neural chaos, picrotoxin. It seems to target the other major braking system.
It does. Picrotoxin comes from the fish berries of an East Indies plant, Anerita cocculus. And it is also a very potent convulsant. It causes clonic, spontaneous seizures, and it also strongly affects the centers that control breathing and blood pressure. Vasomotor stimulation.
And the key difference from strychnine is where it works.
Exactly. The crucial mechanistic distinction is that picrotoxin acts higher up in the CNS. It works by blocking presynaptic inhibition that's mediated through GABA.
Gamma-aminobutyric acid. GABA.
Oh.
Of course. The brain's primary general inhibitory neurotransmitter. It's the main stop sign for neural signaling all across the cerebral cortex.
Precisely. Now, here's where a little technical nuance is important, but we can keep the concept clear for you, the listener. Picrotoxin is not a competitive antagonist on the GABA receptor itself.
Okay, what does that mean?
It means it doesn't fight for the main parking spot, so to speak. It acts on what's called an allosteric site, a secondary binding pocket on the receptor complex. By binding there, it prevents the chloride ion channel from opening. And that channel opening is absolutely necessary for GABA to have its calming inhibitory effect.
So it jams the mechanism.
It jams the mechanism, and this mechanical detail is what distinguishes it from other synthetic convulsants that we study, like bicuculin.
And bicuculin is different how?
Bicuculin is a competitive GABA receptor antagonist. It fights directly for that main GABA binding site. It tries to take the primary parking spot.
So conceptually, picrotoxin is blocking the mechanism that lets the brake pedal work, while bicuculin is fighting for the pedal itself.
That's a great way to think about it, yes.
And finally, in this lovely category of poisons, we have pentylenetrazole, or PTZ.
Ah, yes, PTZ. It's a powerful CNS stimulant, and it acts by directly depolarizing central neurons. Essentially, it floods the system with a positive charge, making neurons fire indiscriminately. It can also interfere with GABAergic inhibition, a bit like picrotoxin. But its major role today is purely in the laboratory.
A research tool.
A research tool, exactly. When scientists need a reliable, aggressive way to induce convulsions to test a new anticonvulsant drug, PTZ is the standard chemical they use. It's a way to stimulate the system globally, but fortunately, its clinical relevance today is zero.
Okay, moving swiftly past the poisons, thank goodness. Let's transition to agents that were, at least historically, used in clinical settings to stimulate the system. These are known as analeptics, or respiratory stimulants.
Right, analeptics. They're primarily represented by drugs like doxapram. Their core function is to stimulate respiration and arousal. And they do this by acting on the medullary vital centers in the brainstem. Those are the areas controlling all our involuntary functions, like breathing and heart rate.
These sound like emergency drugs. What was their historical role? And more importantly, why have they been phased out?
They were absolutely emergency measures. In the past, you'd see them injected intravenously to try and resuscitate patients. Cases of deep coma from a drug overdose, especially barbiturates, or in acute respiratory crises like suffocation or drowning.
So the idea was a chemical shock to the system.
A chemical shock, yes, to jolt the respiratory centers back into activity. But modern medicine has completely abandoned this practice, and for very good reason.
Which is?
The current medical guidelines prioritize intubation and mechanical ventilation. Those techniques are far more targeted, much safer, and incredibly more reliable than trying to aggressively stimulate the entire brainstem with a chemical.
Because the risk is too high?
The risk is unacceptably high. You risk inducing massive convulsions without ever achieving a sustained therapeutic respiratory benefit. They're true historical footnotes now.
All right. So we've successfully navigated away from the global sledgehammers, and now we're entering a much more familiar and I'd say interesting realm, psychostimulants.
Yes, here we're talking about drugs that are defined by their dominant psychic effects. They are still strong central nervous system agents, but their action is much more focused. It's on specific pathways to enhance things like alertness, focus, or mood. And critically, their central actions far, far outweigh their peripheral side effects.
And this category includes some of the most widely recognized, prescribed, and, well, unfortunately, widely abused substances in the world today. Let's start with the big players, amphetamines and methylphenidate.
Amphetamines, right. They come in racemic and dextro forms, and there are synthetic compounds with these profound central actions. Their primary mechanism is centered on two vital neurotransmitters, norepinephrine, or NA, and dopamine, or DA.
The get-up-and-go chemicals.
pretty much. And amphetamines primarily function as releasing agents. They basically force the presynaptic neuron to dump massive quantities of NANDA into the synaptic gap. It just floods the space, driving increased mental activity, vigilance, and even euphoria.
And how does methylphenidate, the active ingredient in drugs like Ritalin, how does that fit into this picture? It's often lumped in with amphetamines, but there are some critical differences.
There are. Methylphenidate is chemically and pharmacologically related to amphetamine, but it operates through a distinctly different mechanism. And this has huge clinical implications. While both drugs result in increased NA and DA concentrations in the brain, which is what gives you that increase in mental activity, methylphenidate is predominantly a reuptake inhibitor, not a releasing agent.
Okay, let's unpack that distinction, because this seems like the core insight for anyone trying to understand ADHD treatment.
It is. A releasing agent, like amphetamine, forces the cell to push out its stored neurotransmitters. A reuptake inhibitor, like methylphenidate, just blocks the vacuum cleaners, the transporters that would normally recycle NA and DA back into the neuron.
So it leaves the neurotransmitters that are already there active in the synapse for a longer time.
For a longer duration, exactly. So you have two drugs that achieve a similar result, more NA and DA signaling, but they do it in two very different ways.
So why? Why is methylphenidate considered superior, especially for treating attention deficit hyperactivity disorder in children?
The difference between forcing release and inhibiting reuptake is profound when you look at long-term clinical use. The source material is very clear on this. Methylphenidate causes significantly less growth retardation and fewer disruptive behavior and sleep disturbances. And this is in a large majority of kids treated, specifically 3 out of 4 children.
That's a huge difference.
It's massive. And while both are effective for concentration, the amphetamine's mechanism, forcing the release of these stores, is thought to be more disruptive to the brain's natural regulatory processes. That leads to those more pronounced negative side effects, like appetite suppression, anorexia, and serious sleep disruption.
So methylphenidate is a more controlled, gentler way of elevating the signal.
It's a less aggressive way of adjusting the neural dial, yes.
Okay, that makes perfect sense. Now let's talk about practical timing. The short-acting forms of these drugs are often dosed twice a day. What's the reason for that, especially with methylphenidate?
Well, methylphenidate is absorbed very rapidly, but its half-life, the T1 half, is actually quite short. It's between 2 and 4 hours.
So it clears out of the blood pretty fast.
It clears from the bloodstream quickly, yes. However, the central effects, the effects on the brain, can often persist longer, and that allows for a twice-daily dosing regimen, usually in the morning and then again in the early afternoon.
I see. So it maintains the therapeutic levels during school or work, but then it drops off in time for sleep, hopefully.
That's the goal, to maintain levels during the primary active day, but let them fall in time for the child to hopefully get a good night's rest.
And despite this preference for methylphenidate, we can't ignore the list of common side effects. I mean, you see them reflected in patient experiences all the time.
Absolutely not. The side effects are a direct consequence of what the drug is doing, enhancing dopamine and norepinephrine signaling. You get anorexia, which, as we said, leads to potential weight loss and growth issues. You get insomnia, abdominal discomfort, and general bowel upset. These are the trade-offs. This is what you deal with when you're manipulating core brain chemistry. And, if we connect this to the bigger picture of precision pharmacology, this whole area raises a really important question.
Which is?
How far can we push the concept of focus and attention enhancement without touching the dopamine system at all? If we could do that, we could avoid the potential for abuse and the really intense stimulant side effects that are tied to DA release.
And that question brings us perfectly to one of the truly modern therapeutic agents, atomoxetine, known commercially as Strattera.
Atomoxetine is a key pharmacological development precisely because of what it doesn't do. It's classified as a selective norepinephrine reuptake inhibitor, a selective NA reuptake inhibitor. And crucially, it's structurally unrelated to amphetamines.
So it's operating entirely outside those powerful dopamine pathways.
Entirely.
Yeah.
It does not enhance DA release, and the textbooks are explicit. It is not a classic CNS stimulant, nor is it an antidepressant, even though it improves attention and concentration.
So it manages to get therapeutic benefits in ADHD for both kids and adults by using a completely different lever. It focuses only on norepinephrine. This must have huge implications for its abuse potential.
Precisely. Because it lacks that dopamine kick, the rewarding high, its abuse potential is dramatically lower than traditional psychostimulants. That's a major, major clinical advantage. However, the use of atomoxetine introduces a significant pharmacological complexity and it's all about how it's metabolized.
Okay.
It's metabolized primarily by an enzyme in the liver called CYP2D6, and then it's excreted.
And why is that specific enzyme important? Why should you, the listener, care about something called CYP2D6?
This is a perfect example of how your personal genetics influences pharmacology. The gene that codes for the CYP2D6 enzyme is subject to genetic polymorphism.
Meaning people have different versions of it.
Exactly. In simple terms, this means people fall into two major categories. You're either an extensive metabolizer, an EM, who breaks the drug down quickly, or you're a poor metabolizer, a PM, who processes the drug much, much slower. And the source material highlights this because it dramatically affects dosing and safety.
So if you're a poor metabolizer, that atomoxetine you take in the morning is going to hang around in your system for much longer. You get a much higher sustained concentration of the drug.
That's absolutely right. And for those poor metabolizers, the concentration can increase substantially, especially if they're also taking another common medication that inhibits CYP2D6, like certain antidepressants, fluoxetine or paroxetine. This leads to amplified side effects and potential toxicity. Clinicians have to perform very careful dose titration, sometimes starting as low as 0.5 milligram per kilogram per day, and carefully monitor patients who might be genetically predisposed to this slow metabolism.
It's a vital lesson that dosage is not one size fits all. It really depends on your liver's machinery. Okay, now we move to a drug that has truly crossed over into cultural consciousness, modafinil, known as Provigil. This has gained an almost mythical reputation as the smart drug or the limitless pill because of how well it promotes wakefulness.
Modafinil is certainly the newer psychostimulant for enhancing wakefulness. It's used widely, not just for approved conditions like narcolepsy or sleep apnea syndrome, but, well, off-label.
By a lot of people.
By a lot of people. Night shift workers, students, tech professionals. They claim it improves their attention span, speed, and accuracy by reducing fatigue and sleepiness, but without that manic, jittery edge you get from amphetamines.
But here's the paradox of modafinil, and it's astonishing. The source material explicitly states that its primary mechanism of action is not known. That's incredible in modern pharmacology.
It truly is. We know it has a non-amphetamine structure, so it's a non-traditional stimulant, but the precise overarching mechanism that's responsible for its very pronounced, very clean wakefulness effect. It's still elusive. We have pieces of the puzzle. It inhibits both norepinephrine and dopamine uptake, a bit like methylphenidate, but it also interacts in complex ways with the glutamate and GABA systems, and maybe even histamine.
But connecting those pieces to that specific feeling of controlled, non-jittery alertness.
The overall picture is still blurry. It is a genuine pharmaceutical mystery.
Let's look at its practical use, how it sustains that wakefulness. How do its pharmacokinetics compare to, say, methylphenidate's short half-life?
Well, modafinil is absorbed within about 2 to 4 hours, but its half-life is remarkably long. We're talking around 15 hours.
15 hours? That's a full waking day.
It is, and this long duration of action is exactly what supports its once-daily dosing regimen. It's perfect for maintaining sustained wakefulness throughout an entire shift. It contrasts starkly with methylphenidate, which you have to dose multiple times to avoid those peaks and troughs.
We mentioned it's approved for narcolepsy and shift work disorder, but the research community has been exploring its unique profile for broader applications.
Absolutely, because it elevates dopamine, but without that explosive release you see with amphetamines, it has been actively evaluated as a drug to prevent cocaine dependence and to treat opiate withdrawal symptoms. The theory is that it can stabilize some of the brain's reward pathways without causing euphoria, which could reduce the intense cravings associated with addiction. It's a testament to its really unique profile.
But even a drug with a mystery mechanism and strong therapeutic use has to come with risks.
Unfortunately, yes. The side effects are diverse, and because of that long half-life, they can persist. You see common issues like headaches, nausea, anxiety, dizziness, and hypertension. But because of its complexity, there's a list of more severe potential effects. Things like confusion, personality disorders, even tremors. And dependence is a possibility that has to be monitored constantly in long-term use.
We simply cannot have a discussion about stimulants without dedicating some time to the most ubiquitous one of all, caffeine.
Caffeine, right. Along with theophylline, it's one of the 3 naturally occurring methylxanthines. It is the stimulant that virtually everyone interacts with on a daily basis. And it's often consumed in combination with other drugs like analgesics or ergots and common pain relievers, things like Cafragot or Excedrin.
What's its core mechanism? How does it compare to the NA and DA mechanisms we've been talking about?
Its mechanism is fundamentally different. While amphetamines and methylphenidate are all about dopamine and norepinephrine, caffeine acts primarily by being an antagonist of adenosine receptors.
Adenosine. Okay, refresh your memory on that one.
Adenosine is a chemical that naturally builds up in your brain over the course of the day. As its levels rise, it signals fatigue and promotes sleep. It's your body's natural sleep pressure signal. By blocking these receptors, caffeine prevents the brain from detecting that crucial signal of tiredness. It effectively overrides the natural physiological urge to rest.
So the jitters, the wakefulness, that's just us temporarily silencing the body's internal fatigue alarm.
That's a perfect way to put it, yes.
And what about the timing, the pharmacokinetics?
Caffeine is absorbed very rapidly, even though it has poor water solubility. It gets distributed widely across the body, gets into the brain easily. It's metabolized primarily in the liver, and its half-life is relatively short, typically 3 to 6 hours.
Which explains why that morning coffee wears off by late afternoon for most of us.
Exactly. Though there are variations, of course, especially if you have compromised liver function.
Now, the therapeutic uses of caffeine are actually quite broad. It's not just about keeping people awake.
Indeed. First, as we mentioned, it's a critical component in analgesic mixtures. The added vasoconstriction and central stimulation boosts the efficacy and the speed of absorption of the pain reliever itself. Second, and this is highly relevant to millions of people, it's used in migraine treatment.
Right, because of the blood vessels.
Exactly. Migraine pain is often associated with the vasodilation, the widening of cranial vessels. Caffeine causes vasoconstriction. It tightens those vessels, which helps reduce the throbbing pain. And third, surprisingly, it has a role in neonatal medicine. It can be used to treat apnea, which is a temporary cessation of breathing, in premature infants. It's actually a safer alternative to theophylline for that purpose.
And the adverse effects, the anxiety, the agitation, that's just an extension of overriding that natural system, right?
That is absolutely correct. The toxic effects are just exaggerated pharmacological actions. You get GI irritation, nausea, vomiting, excitability, insomnia, agitation, muscle twitching, and crucially, high heart rates or tachycardia. At very, very high doses, that central stimulation can occasionally lead to serious convulsions or cardiac extrasystoles. But true, fatal caffeine poisoning is relatively rare compared to other stimulants.
And finally, we should just briefly note that our source material includes cocaine. It's a naturally occurring psychostimulant, profound psychoactive effects, but its mechanism is so tied to addiction pathways that we'll save that deep dive for another time.
A wise choice.
Yeah.
It deserves its own focus.
So now we shift gears completely.
This is where we have to acknowledge the harsh reality of neurodegeneration. We are moving from the goal of global stimulation and wakefulness to targeted cognitive repair. The goal is no longer to make a healthy brain faster. It's to preserve function and quality of life in a brain that is actively deteriorating.
Before we even get into the drugs, we have to precisely define the target. We all hear the term dementia. Pharmacologically, what are we attempting to treat?
Dementia is defined as the progressive impairment of intellect, memory, and cognitive skills, and it has to be sufficient to interfere with daily life. Critically, this happens in the absence of a clouded consciousness or motor dysfunction. It is a slow, relentless erosion of high-level brain function.
And the most common cause is Alzheimer's.
The most common and most important cause is Alzheimer's disease, AD. Pathologically, it's characterized by a triple threat. First, you have the deposition of beta-amyloid plaques outside the neurons. Second, the formation of neurofibrillary tangles, these twisted accumulations of tau protein inside the nerve cells. And third, and this is where the drugs come in, there is a profound and critical cholinergic deficiency in the brain, a massive loss of acetylcholine signaling.
So the primary therapeutic strategies we have are all about correcting that loss.
They revolve almost entirely around trying to correct that loss of acetylcholine, yes. And while these enhancers are explored for things like mild cognitive impairment or multi-infarct dementia, the greatest clinical focus and the strongest evidence remains rooted in Alzheimer's.
This brings us to the general and often problematic mechanism that's proposed for a lot of these so-called enhancers. Many are tested on the premise that they just increase cerebral blood flow or support metabolism.
And this is where we need to introduce a very serious caution. It's true that cerebral blood flow is reduced in AD, but this is likely a consequence of massive neuron loss, not the primary cause of it.
So trying to fix the blood flow is treating a symptom, not the disease.
Exactly. And the efficacy of drugs that claim to improve cerebral circulation is highly questionable. Moreover, a strong, non-selective vasodilator effect, a drug that just aggressively widens blood vessels, could actually be harmful
Harmful, how?
because of a dangerous concept called the steal phenomena. Think of the brain's blood supply as a series of interconnected highways. If one section is compromised, it's ischemic, it's damaged, the blood supply there is already low. If you then use a powerful drug to widely open up all the healthy surrounding highways, you literally divert or steal blood flow away from that compromised ischemic area. You pull it toward the healthier areas.
Oh, wow. So you make the problem worse in the one area that needed the blood the most.
You worsen the ischemic injury. So simple vasodilation is a dangerous and likely ineffective path for AD treatment.
That analogy of traffic control makes the steal phenomenon much clearer. It's a perfect illustration of how fixing one problem aggressively can create a catastrophe somewhere else. Okay, with that caution in mind, let's dive into Category A, the cholinergic activators. These are the current pharmaceutical mainstays, and they aim to augment those low levels of acetylcholine by inhibiting the enzymes that break it down.
The story really starts with a drug called tacrine. It was the first centrally acting acetylcholinesterase, or ACE, inhibitor introduced for AD treatment. But it's a pharmaceutical cautionary tale. It is now entirely out of use,
Why?
largely due to its association with severe hepatotoxicity, unacceptable liver damage in a significant number of patients.
So the generation that followed had to be much better tolerated. Let's start with rivastigmine, often known as Exelon.
Rivastigmine is a carbamate derivative, and it has a fascinating dual action. It doesn't just inhibit acetylcholinesterase, ACE, it also inhibits butyrylcholinesterase, or BUSHI. The source material emphasizes that it's highly selective for a specific isoform of ACE, the GI isoform, which is predominant in certain key brain areas affected by AD. Its inhibition is also slow to wear off, which gives it persistent activity.
Wait, why is inhibiting both of those enzymes, ACE, BUSHI, why is that important? Does that give it a therapeutic advantage?
It might. While ACE is the primary target for breaking down acetylcholine, BUSHI also plays a role, especially later in the disease process or in other cells like glial cells. So targeting both enzymes might provide a more complete augmentation of cholinergic signaling.
And how is it administered?
It's highly lipid soluble, so it gets absorbed rapidly. It's dosed meticulously, though. You start very low, maybe 1.5 milligrams twice a day, and you increase it gradually over months, up to 6 milligrams twice a day. The availability of transdermal patches, skin patches that deliver 9.5 or 13.3 milligrams over 24 hours, that's a huge clinical advantage. It can improve patient compliance and maybe even reduce some of the peripheral side effects.
Then we have Donepezil, Aricept, which is really the current standard bearer for this class of drugs.
Donepezil is a cerebroselective and, importantly, reversible anti-ET drug. It's highly valued precisely because it's relatively non-toxic and well-tolerated, which makes it a reliable option even in the advanced stages of AD. Its mechanism is just cleaner than tacrine, so it has a much safer profile.
What's the reality of its efficacy? I mean, does it halt the disease?
No, and it's crucial to emphasize that. It does not halt the underlying neurodegeneration. It is a symptomatic treatment only. However, it does produce measurable cognitive improvement, specifically in cognitive activities of daily living scores. And this benefit can be sustained for up to 2 years in some patients.
2 years?
That 2-year benchmark is the harsh reality of the treatment. It offers time, it offers stability and symptom relief, but the disease continues its slow progression underneath. Dosing is straightforward, typically 5 milligrams a day, increasing to 10 after the first month if it's tolerated.
And finally, in this category, we turn to galantamine, which adds yet another twist to this cholinergic mechanism.
Galantamine is a natural alkaloid, and it provides a distinct dual mechanism. Like the others, it selectively inhibits cerebral ACE. But uniquely, it also acts as a positive allosteric modulator of nicotinic receptors.
Okay, that's a mouthful. What does positive allosteric modulator mean in plain English?
Think of the nicotinic receptor as a lock, and acetylcholine is the key. A positive modulator doesn't block the keyhole or change the number of keys. It makes the lock itself turn more easily and efficiently when the key is inserted.
So it makes the remaining receptors more sensitive.
Exactly. By modulating the nicotinic receptor, galantamine enhances the sensitivity of the remaining functional receptors to the meager amounts of acetylcholine that are still present. This combined action might provide an extra therapeutic edge. Its efficacy is comparable to rivastigmine and galantamine, and it's also used for mild to moderate AD.
So across all three of these major drugs, donepezil, rivastigmine, and galantamine, What's the common denominator in terms of side effects?
They all share the consequences of increased cholinergic activity, which affects systems outside the brain. This leads to common peripheral and central side effects. You see anorexia, which can result in weight loss, insomnia, fatigue, nausea, and general bowel upset. And the central effects can include confusion and sometimes even hallucinations.
The overall takeaway seems to be that despite decades of research, these three drugs are still the primary strategy. It really highlights how difficult cognitive repair is.
It does. Which brings us to category B, the glutamate antagonist. This is where we step outside the cholinergic system entirely and target a completely different pathology in AD, something called excitotoxicity.
And this brings us to memantine, known as Namenda.
Memantine is a newer NMDA receptor antagonist, chemically related to amantadine. It's generally reserved for use in moderate to severe AD, as its benefit in the milder stages is less clear.
Why target the NMDA receptor? That's the primary receptor for glutamate, which is the main excitatory neurotransmitter. Why would you want to block the GO signal?
The theory centers on glutamate excitotoxicity. Now, while glutamate is essential for learning and memory in Alzheimer's as the neural environment breaks down, you get this chronic, excessive, low-level stimulation of the NMDA receptor. It creates a constant, damaging state of overstimulation, a slow, chronic burn that eventually kills the neurons. Memantine acts as a partial NMDA receptor antagonist. It dampens this destructive overstimulation. It restores some functional decline and provides a neuroprotective effect. It allows normal transient glutamate signaling to happen, but it prevents the chronic, damaging noise.
And it has other uses too, right?
It does. It's interesting to note its utility extends beyond AD. It's also used in treating Parkinson's disease.
And compared to the ACE inhibitors, how is memantine tolerated by patients?
Generally, it's considered better tolerated.
Right.
It has fewer of those peripheral side effects, though patients can still experience constipation, dizziness, and headache. In many clinical settings now, memantine is used concurrently with an ACE inhibitor to try and address both the cholinergic deficit and the excitotoxicity pathway at the same time.
Okay. And finally, we arrive at category C, miscellaneous drugs. This feels like a collection of compounds that are used globally, often marketed aggressively, but they frequently lack the robust controlled evidence demanded by, say, the US or European regulatory bodies.
That's a very fair assessment. This group represents the ongoing and often desperate search for a simple, effective repair. First on the list is piracetam. It's a GABA derivative, but its precise mechanism for cognitive enhancement is completely unknown.
But it carries this nootropic label.
It does. The label nootropic suggests it should have this selective, high-level, pure cognitive enhancement activity. But that label is entirely aspirational. In reality, it lacks selective, proven efficacy in large-scale trials.
Next, we have pyritinol, a derivative of pyridoxine.
Right. Pyritinol is not an approved drug in the U.S. for cognitive benefit. Its proposed action is metabolic. It's believed to enhance glucose transport across the blood-brain barrier, essentially trying to get more fuel to those struggling neurons. It's used globally for memory deficits and senility, but its therapeutic benefit is highly uncertain.
And the older semi-synthetic alkaloids like dihydroergotoxine.
A semi-synthetic ergot alkaloid. And like many others, it's claimed to increase cerebral blood flow, but its therapeutic value is almost universally seen as weak and largely unproven. Just serves as another reminder of our earlier caution. Simply trying to widen blood vessels often fails, or worse, harms the patient due to that steal phenomenon. We should also address citicoline, which is remarkably popular globally under trade names like somazina.
Citicoline is interesting because it's derived from choline and cytidine, two molecules that are heavily involved in just maintaining cell membranes.
Correct. It plays a role in the biosynthesis of lecithin, a major membrane component. Proponents claim it works by increasing cerebral blood flow and enhancing cerebral metabolism, effectively helping neurons repair their internal structure. And while some short-term improvement in memory and behavior has been shown in some studies, especially after a ischemic stroke or head injury, the convincing long-term evidence needed for a clinical endorsement in AD is substantially lacking.
Our final item is perhaps the best-known natural compound in this entire section, ginkgo biloba, the dried extract of the Chinese tree, which everyone hopes is the easy, natural answer.
Ah, ginkgo. It contains active compounds like ginkgo flavone glycosides. The theory, based on its ability to act as a PAF, or platelet activating factor antagonist, suggests it might prevent cerebral impairment that stems from vascular insufficiency,
So helping with microstrokes and things like that.
perhaps helping in thrombosis or infarcts, preventing the small microstrokes that contribute to vascular dementia. That's the theory.
But theory versus clinical reality often diverges sharply, especially with natural supplements.
They certainly do. A rigorous systematic review, a Cochrane meta-analysis, concluded that ginkgo biloba produced only minor overall improvement in cognitive performance across various trials. The results were generally inconsistent, and a major limitation is that many of the trials they reviewed were just too small to be statistically conclusive.
And there are side effects to consider.
Absolutely. While generally mild, mostly upper GI symptoms, there's an increased risk of bleeding, and that's a significant safety factor to consider, particularly in an elderly population that might be taking other blood thinners. It's a classic example of a compound with strong theoretical potential that just hasn't delivered robust clinical proof.
So what does this all mean? We've completed a truly expansive journey through this whole spectrum of CNS acting drugs. We've gone from these potent, indiscriminate toxins like strychnine all the way to the highly focused psychoboosters like methylphenidate and atomoxetine, and finally into this ambitious but very heavily constrained world of cognitive repair.
The fascinating dichotomy we see today is just so stark. On one hand, you have stimulants like caffeine and amphetamines that boost function globally through these powerful generalized mechanisms, dopamine, norepinephrine release, creating immense energy and focus. And then, in sharp contrast, the quest for true cognitive repair through enhancers is a fight against decay. It's tied up in these subtle, targeted, and sometimes unproven metabolic or neurotransmission theories.
And even the successes are limited.
Even the most successful interventions, like donepezil and the other ACE inhibitors, are so limited in scope and duration. They offer a measurable benefit for maybe up to 2 years. They are crucial for symptom management, but they do not solve the underlying disease progression.
Reflecting on your journey, you, the listener, now have a clear roadmap through this complex pharmacology. You are armed with the specific mechanisms blocking glycine, the critical difference between reuptake versus releasing agents, the dual action of galantamine. You know what makes methylphenidate superior for ADHD, why atomoxetine is considered a non-stimulant alternative, and why modafinil remains this tantalizing pharmacological mystery. And you understand the dangers of the steal phenomenon when we pursue simple solutions for complex neurodegeneration.
And this all raises an important question for the future. Given the known, precise mechanism of a drug like atomoxetine, which manages focus through selective norepinephrine reuptake inhibition, and the fact that researchers still don't fully understand the action of modafinil, which is used for pure wakefulness, how much closer are we to truly isolating and manipulating the specific neural pathways responsible for pure focus and attention, entirely separate from the global buzz or the addictive potential of traditional stimulants? The future of cognition enhancement seems destined to move away from these sledgehammer stimulants and toward an unparalleled, maybe even genetic level, precision targeting. A targeting that might one day, hopefully, overcome the massive challenge of treating the neurodegenerative brain.